cardiac MRI pulse sequences?
Yes, I can see it, Harry. Go ahead.
Okay, so I'm going to talk to you a little bit about MRI physics without getting into the deep quantum physics of it all, because that scares me, and I'm sure it'll scare you as well. And what I want to do is I want to give some broad principles and say why the heart is different, what we do different in the heart. So with any imaging, there are a few things we need to keep in mind. We need the signal, we need to generate a signal. But if everything had the same signal, then you would not really be able to see one structure from the other. So we need to generate contrast. Things must be looking different. That's a key principle. And we also need to localize where things are. And in some cases, we need a dynamic temporal component to it, time. So if you think about it as a 4D thing, this is one way of looking at it, the 4 components of imaging. Some basic MRI, I'm not going to go too much into it, except that place the patient in a magnetic field where you get a net magnetization vector in the direction of the magnet. And in order to generate the signal, you tip the magnet field, which is precessing like a spinning top at 90 degrees. And at that point, you can get a T1 recovery or T2 decay. And tissues have different rates of T1 recovery. The T1 recovery is where you go back to the original state of your longitudinal magnetization. And T2 decay is when, by virtue of being pulled into the XY plane, the transverse plane, you get transverse magnetization, you get a decay of that time. One nuance is that you don't have to tip the magnetization by 90 degrees. You can do it by what's known as alpha, the flip angle, in which case you have a residual longitudinal magnetization, a residual transverse magnetization. And that leads to the prospect of having both T1 and T2 weighting. So it's not either or, it can be both. So why is the heart different? So 3 very obvious facts. One is that the heart moves, and with it, the blood in the heart moves too. The second is that the heart has an electrical signal, and there is periodicity to its movement. It's not erratic, at least not when we want to image. And the third is that they have very different tissue characteristics. So the blood and heart are different tissues altogether. And how we exploit those characteristics is the basis of cardiac imaging. So the movement of blood, the electrical signal of the heart, and the tissue composition of both. Remember that we're creating a contrast, and the contrast can be between whatever we want to create a contrast between. So we have to think about properties that can be differentiated in order to create that contrast. So let's look at some very basic principles going back to the contrast. If you want to create what I call angiographic contrast, meaning making the stationary tissue and blood different, you have to exploit certain properties of the blood that are not present in the stationary tissue. One obvious property is that the blood moves. Stationary tissue, by and large, doesn't. It moves a little bit, but not a lot. So flowing blood is dark on spin echo imaging. Why is that? So spin echo imaging, you need 2 pulses, the 90 degrees refocusing, 90 degrees tipping pulse into the XY plane, and then the 180 degrees refocusing pulse. Flowing blood, if it flows fast enough, will get one or the other, but not both. And so it appears dark because it has not received the refocusing pulse or the tipping pulse. And if it did, then it would appear bright. Why? Because there would be some T2 weighting, and blood, composed mostly of water, has some T2 weighting. So MRI, we're dealing with vectors. And unless you're exactly perpendicular to the imaging plane, there's going to be components of the transverse and longitudinal magnetization that will persist. So what that means is that the degree of voidness, the on spinnaker image, depends, of course, on the speed. Faster the blood moves, more likely it is to either escape the 90 or the 180 pulse in spinnaker. Directionality, if it moves absolutely perpendicular to the plane of imaging, then there's less likely to have a vector hanging around. And the third is the echo time. The longer the echo time, the more time you give it before you apply the refocusing pulse, and therefore more time is allowed for the blood to leave the slice. So you'll notice over here that there is the ascending aorta structure here, which is a large descending aorta. Whereas in ascending aorta, the blood appears very dark. Not surprising, because the aorta carries arterial blood, which moves it fairly fast. And this is the superior vena cava, which also appears dark, although it has some little white patches here. But in the descending aorta, there's a large chunk of it where there is no darkness, and there's a small chunk of it where there is. So in your minds, you should write down what you think the diagnosis is and why. So this patient has a dissection, a tear in the aorta, the descending aorta. This is the false lumen where the blood flow is slow. This is the true lumen where the blood flow is fast, or as usual. So in the false lumen, blood actually doesn't escape the slice and gives out signal as it's supposed to give out. All right, so now I've explained something to you. I've explained that angiographic contrast, you want the wall to be different from the moving blood, which can be done in one of two ways: by the inherent property or by the fact that the blood moves. I also showed you an example that sometimes blood moves not fast enough, and therefore you can't really always rely on the movement of the blood to create that angiographic contrast. So how else do you do it? Before I get to that, let's look at these four images. They all have one thing in common. What is that? This is a flare. This is stir. This is what we call the double inversion recovery. It's not your usual spinnaker, and this is your inversion recovery to suppress myocardium, late gadolinium enhancement. So this is an inversion recovery. What happens with inversion recovery is that the magnetization is tipped. It's normally plus Z. It is flipped all the way on the other side and becomes minus Z. So like you do the whole thing, the whole body, or whatever, the slice of the body, you flip it on the opposite side. And then different tissues recover their original magnetization and they all start running. But depending on their T1 recovery time, some tissues recover faster than others. For example, fat is faster than blood. Myocardium, fat is faster than water. Myocardium is faster than CSF. And gadolinium, or tissues that have lots of gadolinium, is the fastest because that's the shortest T1 time. You can calculate this particular time, which is the time when the magnetization crosses the 0 point. So if you were to, an inversion recovery is a pre-pulse, which is a pulse you give before the main pulse. If you were to apply the main pulse exactly at the time when fat crosses the 0 point or reaches the 0 point, then you will have in effect suppressed fat. You do the same for blood. You wait a little bit longer, of course. You do the same for blood, you suppress blood. You do the same for CSF, you suppress CSF. So based on the T1 recovery speed, when you do a inversion recovery, different tissues cross the 0 point at different times, and therefore that's an opportunity to suppress that tissue, to do the pulse sequence, the main pulse sequence, exactly when that tissue reaches the 0 point where it doesn't actually give any signal whatsoever. A few other things to appreciate: if you are +3 on this side of the 0 and -3 on this side of the 0, signal that you generate is the same. And that's called magnitude imaging. So if your +3 is the same as your -3, if you remember from your arithmetic days, 3 times 3 is 9, -3 times -3 is 9. So it behaves in that kind of property. That's the first thing to appreciate. That will be important to understand when we're talking about late gadolinium enhancement. But the other thing to appreciate is that when you do inversion recovery, all tissues lose some signal. So whether you're doing, whether you're inverting fat, which is known as stir, or you're inverting CSF, or you're inverting blood, all tissues lose some signal, so it dampens everybody's enthusiasm. And remember what I said about contrast. Contrast is the difference between signal between two tissues. If you have a lot of signal to start off with, you'll have a lot of signal left when you subtract one from the other. If you have very little signal to start off with, you start subtracting, you'll have very signal left. So it's a difference between subtracting, taking $2 from $10, you have $8 left, and then taking $20 from $100, you have $80 left. 80 is of course more than 8. So you have more money, you have more signal, more contrast, the more signal you start off with. So these are the characteristics. It's pre-pulse, can be used both before spin echo, gradient echo, so it's not really married to spin echo. And then it dampens everything down a little bit. And essentially, this is a form of T1 imaging, although it gets a little complicated because there's a T2 component as well. All right, so why do you need to invert the blood? So one of the things about the angiographic contrast and the voidness of blood on traditional spin echo is that you have in-plane movement of blood. You have blood that is moving through structures that are not orthogonal and slow-moving. And you can see the difference if you have, the difference between these two is this here, we're only relying on the motion of the blood. Here, this is an inversion recovery where we are actually suppressing the blood. So we did the imaging when blood crossed the 0 point. So that is the what we call double inversion recovery, and I'll explain the double part a little bit later on. So why double? Why do we need 2 inversion pulses? The thing with MRI physics is that everything is kind of related. So go back to what I said about inversion recovery is that it dulls all myocardial tissue, and not just the fat in the water, including the myocardium itself. And so what you don't want to do is you don't want the myocardium to be dead. You want the myocardium to be alive in order to create the angiographic contrast. So what we do is we do a non-selective pulse that covers the entire slab. I'm calling that the volume. So everything in that volume is inverted. Immediately, the slice we're interested in, we bring that back to life so that we don't want the myocardial tissue to be dampened in that recovery of the pulse. So if you're a blood spin and you start outside the slice, you've been inverted. And therefore, when you enter the slice, you don't give signal because the main pulse is done when you've got to the 0 point. If you're a spin inside the slice, by the time you do the main pulse, you've left the slice. So we're not concerned about you, concerned about the blood that's moving into the slice. And if you're a myocardial spin inside the slice, then you're brought back to life by the pulse, and now you have signal. But that's fine because we don't care. We're not concerned about your signal. We just don't want you to be different from the blood, and you are because you're being brought back to life. It so happens, and this is where things can be very fortuitous, is that the inversion time of blood, rather let's start with the T1 time of blood is such that the inversion time of blood, when falls in diastole, when you coordinate the whole thing with the R wave of the ECG. So why is that important? Firstly, you need to coordinate cardiac imaging with some point of ECG. That's the whole point of synchronization. The R wave is the most prominent point of the ECG, unless there are certain conditions in which it's dampened. And if you time the pulse from the R wave, you end up in diastole. It's fortuitous because diastole, the motion is the least, and therefore it's much easier getting temporal resolution to resolve what's going on in the heart. So it's a nice little fortuitousness of cardiac imaging. So I spoke about one sort of imaging, which we can broadly call dark blood imaging. Another type of imaging is going to be the bright blood imaging. Just as in dark blood imaging, the angiographic contrast is because of the flow of blood, so it is so in gradient echo imaging or bright blood imaging, where flow makes the blood bright. Why is it so different? Why does in one flow make the blood dark and here flow make the blood bright? Because there's a fundamental difference between spin echo and echo, gradient echo. In spin echo, you do a 90 and a 180 pulse, and the 180 pulse is the refocusing pulse. Gradient echo, you do multiple gradients, which lead to dampening of the tissue, of the stationary tissue, but the blood, which is fresh, hasn't been dampened by the multiple pulses and is able to generate signal. But even with gradient echo, just as in spin echo, we want to suppress blood for its own properties and not rely on motion. We want to do that in gradient echo as well, and we use what's known as balanced steady-state reprecession. It's been around for a while. It's no longer a novel sequence, but it's a very clever sequence. It does a few things very nicely. So firstly, with balanced steady-state reprecession, it's one of the sequences where you have both longitudinal magnetization and transverse magnetization floating around. And that's good because they both give you something to an attribute. So you're not a one-trick pony, now you're a two-trick pony, T1 and T2. And so that means the contrast it generates is greater than if you were simply a one-trick pony. Contrast it generates is not based on the T1 time or the T2 time, but the ratio of T2 to T1. So three disparate tissues with very different T1 and T2 times, fat, blood, and water. They have very similar signal on balanced steady-state reprecession because their T2 to T1 ratios are the same. It generates very high signal to noise ratio in short time, which really kind of goes against the holy grail of MRI, where the longer you sequence, the higher the signal, but here it's the opposite up to a limit. The shorter the repetition time, the higher the signal. And then there are other quirks where T is half TR. And it's also exquisitely sensitive to anything that unbalances the magnetization. And that, of course, includes metal. So you can see the difference between balanced steady-state reprecession and conventional spin echo. The major difference you'll see is that the blood is brighter. And the blood being brighter is because we're not relying on flow properties. We're relying purely on its inherent property. Because the blood is brighter, the contrast between the myocardium and the blood pool, the interface, is much better defined. So the measurements that you get from balanced steady-state reprecession for heart cine function is slightly different to what you get from conventional spin echo. Okay, so this is probably one of the most important sequences we do with the heart, where the sequence essentially functions as a biopsy of the heart, kind of a tissue characterization, as we call it. And it works on two principles. The first is that gadolinium reduces the T1. So whatever your T1 is, tissues that take gadolinium up, your T1 becomes shorter. Blood, of course, takes a lot of gadolinium if you image it at the right time before it disperses everywhere. It's arterial blood, so that can have the shortest T1. There's another interesting principle in if you have injured tissue in the heart, injury from heart attack or from diseases that cause fibrosis or are caused by fibrosis, gadolinium stays in the diseased myocardium longer than it stays in the normal myocardium. In the normal myocardium, gadolinium gets there faster, leaves quickly. Diseased myocardium gets there slower and leaves stays there longer. So at some point, there's going to be a lot of difference between the amount of gadolinium in diseased myocardium versus the amount of gadolinium in normal myocardium. It's an optimal point, meaning that if you image too quickly after you give gadolinium, the two tissues won't be that different. If you wait too long, there'll be washout, they won't be that different. But there's an optimal point at which there is maximum difference, or a good amount of difference. So what does that mean? Remember I said that gadolinium shortens T1 time. So tissues with a lot of gadolinium will have shorter T1 time versus tissues that have very little gadolinium. So instantly there's a difference between the T1 time. There's a difference between any tissue's T1 time, then there's going to be a difference between the time at which they cross the 0 point. So if you apply inversion recovery, you can suppress one tissue and not the other, and vice versa. So here's what we do. We exploit this. Here is the infarct, which contains gadolinium. And so it rushes towards the 0 point. And here is normal tissue, which doesn't contain gadolinium. And at this point here, when normal tissue crosses the 0 point, the infarct, which has more gadolinium, there's a nice difference between the two, providing we wait long enough for that difference to be accentuated. And you can see what happens here. We are doing that exactly, and signal is different because we are acquiring images at different inversion times. And there is one inversion time. I'll try and get this exactly where I want it to. Try this time, one more time. Ah, there you go. So notice this inversion time here. What do you notice about it? The myocardium is dark. Why? Because we have suppressed the normal myocardium. So we're talking about this time over here. There's this little bit over here, sliver here, that is bright. That's diseased tissue. That's this over here. And this is the blood pool that contains a lot of gadolinium. And this is somewhere over here. So in order to pick up pathology, we use inversion recovery. We use inversion recovery because pathology and non-pathological tissue have different T1 times after we give gadolinium, And actually they have different T1 times even without gadolinium, but we won't go there just for this introductory session. And we do that if we wait long enough, the difference in the gadolinium content is going to be maximum. So somewhere around 12 to 15 minutes after the gadolinium. So this is the principle of inversion recovery. So why is that important? It's important because, see, this is all normal myocardium and this is diseased myocardium. You could ask, why didn't we suppress the diseased myocardium and let the normal myocardium be bright? It's easier to see pathology if it's brightness because it's more visually congruent than if it was the other way around. So this person has an infarct, the whole septum of the myocardium, the whole thickness of it is dead. It's fibrous tissue, it's no myocardium. So we'll go to another concept. We'll get slightly more heavier in terms of physics, but not that much. So when we talk about synchronization of imaging, it's easier to understand with CT, where you have an ECG and the scanner is collecting the data and the CT is scanning the patient. It's collecting the data at particular times in the ECG. But what about MRI? MRI, it's a little bit more difficult to understand because MRI, we sample what's known as the case space, which is a little complicated, where we Fourier transform the image, fast Fourier transform it into this imaginary but real space, which then gets fast Fourier transformed to the image. we collect lines of K-space, which are essentially phase encoding steps. So if we have phase matrix of 256, we need to collect 256 lines of K-space. ECG synchronization simply means that we collect lines of K-space with the ECG in mind. So from one heartbeat to the one heartbeat to the one heartbeat to one heartbeat, we collect certain lines of K-space. So let's say we need to collect 256 lines of K-space. Just want to make the math easier over here. Then we collect 16 lines of K-space per heartbeat. And we have to collect 10 heartbeats will get us to 160. And 16 heartbeats will get us to 256. I think I've done that right. I can't remember my times tables anymore. So this collection, this segmenting the K-space that you need to collect in the heartbeats is known as segmented K-space imaging. So you can understand instantly a few things, which is that the number of heartbeats, the number of lines of K-space that you ascribe to any particular heartbeat, let's say you collect 24 lines of K-space instead of 16, you would have collected your requisite K-space faster, right? So number of lines per heartbeat that you collect, if it's few, take longer, if it's more, take shorter. If your phase matrix is greater, 256 as opposed to 120, you'll need more heartbeats, all things else being equal, to fill that complete matrix. So you can instantly see there are some trade-offs over here. One is that the acquisition time depends on the number of lines of K-space you require per heartbeat and the phase matrix. If you shorten your phase matrix, your acquisition time is shorter. If you lengthen your phase matrix, your acquisition time is longer. As you know that in MRI, there are always trade-offs. There's no free lunch, although sometimes you get dessert, second helpings when you don't really need it. So what it means is that there's a trade-off between acquisition time, how fast the imaging is done, and also the phase matrix, which determines your spatial resolutions. The two, acquisition time and spatial resolution, are inversely linked. Finer your spatial resolution, the longer your acquisition time, vice versa. The other interesting thing, which is kind of counterintuitive, is that the number of lines of K-space you require per heartbeat increases your temporal resolution. So if you require 10 lines of K-space per heartbeat, you have a faster temporal resolution than if you require 20, which creates an interesting counterintuitive trade-off, which is that the faster your acquisition, the worse your temporal resolution. That kind of takes a little bit of getting used to, because we kind of think of temporal resolution as your acquisition speed, but here it's not quite the same. Slower your heart rate, the longer your acquisition, because however many lines of K-space that you take per heartbeat, each heartbeat takes longer to do, so your breath hold is longer. So one thing that is also not often understood is that cine imaging using K-space segmentation isn't what happens in one heartbeat, but it's the average of what happens over 10 heartbeats, 12 heartbeats, 15 heartbeats, which is fine if those heartbeats are regularly spaced. If you have a regular heartbeat, if you have an arrhythmia, PVC, that throws everything off, then you can get artifacts, which is what you're getting over here. So how do we deal with this artifact? One way of dealing with the artifact is dealing with the patient's heart rate, which is not always easy when you're at the scanner and you're a radiologist who doesn't really know much about dealing with heart rates. We can make it real time, meaning make it as true to the actual events happening as they're happening. Real time doesn't mean live, real time just means whatever happened, you captured it to its greatest fidelity to how it's happening. We can either do that by reducing the phase matrix. Instead of 160, we can make it 120 or even 80. We will be penalized. We'll be penalized mostly by the spatial resolution. And the second is that we can get what we need to get from K-space sooner. And there's a property of K-space which allows us to do that, which is that the center of K-space gives you most of the contrast. So like if you do the center 5%, center 10%, you've got your image, although it's not a great image, but it's good enough. You do the opposite, like the peripheral 5%, you can get not so great images. So here's an example of a real-time image. This patient has a pericardial effusion, which is pretty large. You can see the right ventricle being compressed by that. It's achieving real-time status because it has a ridiculously low phase matrix. I can find it somewhere. But yes, it is ridiculously low. Somewhere in the order of 80. Here's another example. Same patient, same idea, and you can see that there's a pericardial effusion and the RV wall beat to beat is like kind of being deformed by the effusion. Okay, so now I want to recap on a few things to get an idea. Angiographic contrast, of course, depends on the flowness, movement of the blood, but that's not enough. So we have to exploit blood's inherent property. Inversion recovery is one way to do that. Inversion recovery leads to the dulling of all tissues, which leads to that situation where you don't get much signal, that we don't get contrast that is good enough to give you to be visually detected. And so therefore we apply a second inversion recovery pass to restore signal in stationary tissue. Contrast in balanced steady state pre-precession is a combination of T2 to T1. Therefore, three tissues look bright: fat, blood, and water. Segmented K-space imaging, which is how we do most of our CNA imaging, isn't live, isn't real time. And the fact that we can create T1 differences by giving gadolinium means we can use inversion recovery to invert a tissue that has more gadolinium so that we can see tissues that have, or invert a tissue that has less gadolinium so that we can see tissues that have more gadolinium and therefore see pathology more clearly. All right, I'm going to end here, and I'm happy to answer any questions you may have.